Okay. So I might start. It's just now gone past 6 o'clock, and it's probably just to keep everything on time. We might just get everything underway, if that's okay. So as always, if I could ask everybody who's online to keep their microphones on mute, and that way there's no echoes or reverberations in the sound quality. So tonight's webinar, and welcome everybody. I hope everybody's staying well. It's certainly, I can imagine the amount of haircuts that are needed at this stage is probably getting quite severe. I've managed to do my own DIY version of it. Most would say it doesn't look any different, but I guess it's easy to do a number 2 back and sides all round. Is probably not that difficult to do. So we'll kick off today, as usual, by inviting the president to kind of give us a bit of an update on what's been involved and where the college has been involved with the HSE and the department, and some of the main issues that are emerging out there and the topical matters that are around. And then get on to the substantive topic for this evening, which is looking at the challenges around cancer surgery during the COVID-19 pandemic. And tonight, then, we've a good range of speakers. We're joined by Professor Arnold Hill, who's the NCCP National Surgical Oncology Programme Clinical Advisor and Dean of Medicine in Beaumont Hospital. And just to, particularly congratulate Arnie and all the team in RCSI in having the virtual graduation of the students today, which is a huge achievement for everybody, and indeed for everybody involved with all their university medical schools for all the work they've been doing in looking after the students. And I think it stands that Irish medicine is just incredibly innovative and adaptable, and very conscious of looking after students and patients and so on. So well done to everybody there. We're also joined then by Mr. John Kinsella, who's a head and neck consultant surgeon in St. James's Hospital, and Mr. Eamon Rogers, who's the NCCP rep for urology and is the National Clinical Advisor for Urology in the National Clinical Programmes of Surgery, and then Mr. Paddy O'Malley, who's again also a consultant urologist and a robotic surgery lead in University Hospital Galway. And they're going to talk to us about a range of issues in managing cancer surgery during the current situation. We were going to have a discussion around the possible litigation issues, but unfortunately the representative from the Clinical Indemnity Scheme just is unavailable today due to other duties that have emerged. We'll certainly come back to that one in future webinars. So without any further hold up on things, I'd like to invite the President, Mr. Ken Mealy, to give us open up the session tonight for a few minutes. Thank you. Over to you, Ken.
Thank you very much, and I'd like to welcome all of you to this. I think it's our 4th webinar. All of you are well, likewise your family and colleagues. Initially, when we set up this webinar series, it was to try and engage with our members and fellows surgeons around the country and support you in whatever way we can. The previous webinars have concentrated on topics, particularly in relation to safety and well-being, safety of yourselves, and well-being, particularly of our younger surgeon and trainees. There's been a lot of emphasis on PPE, and a lot of our engagement with the Department of Health and the Health Service has been around designing protocols and care pathways, which we've published and updated extensively on the website regarding PPE and your safety. So we would direct you to those, to the website and the various guidelines. We've collated a lot of information from specialty bodies around the world, our sister colleagues in the UK also. And many of our specialty groups have contributed information, which is all very helpful. And the purpose of this is to try and support you in the difficult decisions and difficult areas of practice that you are engaged in. As the weeks go by, however, we think we should be more specific in the topics that we address, and tonight reflects that. Many of you have contacted me and Surgical Affairs Department over the last number of weeks, particularly in relation to cancer surgery, hence the topic tonight. And I would like to also thank the speakers for coming on board to share their thoughts and their reflections on how we should manage urgent care, particularly in relation to cancer. As I've said, we have previously concentrated on safety, well-being of surgeons, and in that regard, we do have some good news to highlight today, because today the Times Higher Education University Impact Ranking for 2020 was announced, and in one of the domains, good health and well-being, RCSI has been voted #1 in the world. And this is really a boost to all the RCSI staff, the academic and clinical staff, and reflects the work that has gone into gender diversity and inclusion over the last number of years, and the various support programs for both undergraduates and postgraduates. So I'd like to congratulate all of the RCSI staff, academic staff, administrative staff, and our clinicians for supporting these programs, reflecting in this award, which was announced today. In addition to and supporting good health and well-being, we will be releasing more information and courses on the website in relation to communication and support for staff. And these courses have been put together by Professor Oscar Traynor, Professor Eva Doherty, Professor Sean Tierney, and Professor Peter Gillen. And we hope to have more information on these courses and communication for some of the difficult scenarios many of you have to deal with during this period. And we'll upload those onto the website in the coming days. In next week, the webinar will look at returning to normal activity, if that's ever going to be possible, because many of us feel that it may be a long, long time before we do return to normal activity. But we need to do some work in this regard, and we currently are working with the Department of Health and the HSE and various other bodies to design protocols for the safe return to work, so that patients can be tested, staff can stay healthy, and as we increase the amount of surgical work, which we hope is going to happen over the coming weeks and months. And we all feel that there will be problems because of the unmet needs of what has not been done over the last 4 to 6 weeks. So this is a body of work that we will engage in, and this will be reflected in next week's webinar. As always, we ask for your feedback. We would like, all of us would like to know how we can support you better. Is there more information you need in particular areas? Are there topics that we need to address so that we can take these on board for future webinars? So that is all I have to say. Again, I would stress the importance of your safety and your team's safety, because if you are not well, you cannot provide care for our patients. And this is going to become increasingly important as surgical care, we believe, will be reintroduced into the system, whether it be in the public or the private sector. So it is vitally important that all of you remain well. So thank you for listening to me. And as always, I thank Kieran and his team for putting together these webinars, and I'll hand up back to Kieran.
Thank you, President. That's fantastic, great update, and certainly, you know, tonight's discussions will be very relevant to all the points you made there. And just to remind everybody, we use the chat function on Microsoft Teams. You'll see a symbol on the screen which allows you to type in a message or a question or a comment that you'd like put to the panel at the end of the presentations. Throughout as well, we will, the team in the back room here, will be putting up links to the guidelines and other documents that are on the RCSI website in the COVID-19 update section. And they'll put those guidelines up as the speakers refer to them in their presentations. And again, all of the presentations and the videos will be available to everybody on the RCSI website to review and indeed use for any tutorials or presentations or any way you need to use that. And again, we're very grateful for all the participants in sharing their information with all their colleagues. So our next speaker is going to be Professor Arnold Hill, and who I think probably needs no introduction, but I have to introduce him anyway. He is the NCCP National Surgical Oncology Programme Clinical Advisor, and he's going to give us a perspective, a national perspective, on the current NCCP guidelines for dealing with cancer surgical cases in the current situation. So Arnie, I'll hand it over to you, and thanks again.
Thanks so much. I'll put up the slides from here, actually, if that's okay. Can you see that screen okay? Kieran?
Yes, Arnie, we see your screen there now. So yeah, you work away on that.
Okay, great. So I'll just go back to the beginning, sorry. So I've only 9 slides, you'd be glad to know. And thank you very much, Kieran, for the chance to share my thoughts from, I have a role as the Surgical Oncology Advisor in the NCCP, and clearly there have been huge changes to cancer surgery since the end of February when this coronavirus outbreak hit. And I think it's fair to say you can only describe them as catastrophic, the changes and the difference of what we're doing now compared to what we were doing in January. Elective surgical cancer care has been radically changed, and it's been minimized. To give you an example, there are normally 12 theatres running in Beaumont. There's 2 at the moment running for cancer surgery and 1 for emergency. So 9 theatres missing, a huge volume disappearing. And the question is, what I want to go through tonight is what's happened at NCCP in terms of what's being done, what type of cancer work is still going on, and maybe a thought about the future and what might happen. I think the real issue that struck everybody was early on in this outbreak was there was a paper from Conor Delaney in the Cleveland Clinic who shared work with his experience of people who had worked in Iran in the month of February. And they actually published on 4 papers, or 4 patients, extraordinarily small. 3 of them, they're all patients undergoing elective surgery, hernias and gallbladder surgery and morbid obesity surgery. And 3 out of 4 died, and 1 spent numerous days in ICU. And these were all asymptomatic patients who were undiagnosed COVID positive patients. And they were alerting us to the risk of operating in the asymptomatic COVID positive patient. And that really caused a significant fear. There has since been a paper out of China which described a 20% mortality in patients undergoing elective surgery who were asymptomatic, undiagnosed. And that is really the basis of the major shutdown in elective cancer surgery. The fact that you may not know someone may be asymptomatic, carry the virus, you do a straightforward operation, and they die subsequently. And clearly, that's an unacceptable risk. So that's been the challenge. Those 2 publications and the uncertainty about patients, whether they carry COVID or not. And the difficulty we face is that if you do a swab test, it's only 65% accurate. So there is a false negative rate in doing a COVID swab. For those doing thoracic surgery, one of the modalities that have been chosen is to do a CT scan. And if you can, there are classic features of COVID positivity in the lungs on a thoracic CT scan. And that has been utilized by those doing esophageal surgery and lung resection surgery. So that has been one way of trying to reassure yourself that the patient isn't COVID positive and that you won't get an unanticipated bad outcome. But remember, we're limited in the accuracy of the test. They say if you have 3 swabs negative, that you still only have a 65% certainty that they're truly COVID negative. So it's in that background of uncertainty where there's been really what has precipitated the major shutdown in elective cancer surgery. Very realistic, very justifiable. We're operating here in a vacuum where our knowledge levels are only so good. So just to go through the number of procedures and the issues, the real issue, if you're doing a procedure that involves aerosolization, that's a no-no at the moment. So our neurosurgical colleagues here in drilling into the skull, that's an aerosolization procedure, and if the patient is COVID positive, that's a risk to the staff. Upper GI endoscopy, because the patient, if you're intubating them or putting the endoscope in and they cough over you and they're carriers of the COVID virus, that's a huge risk to you. Head and neck surgery, I'm sure John Kinsella is going to talk about this, but essentially they, in dealing with tracheostomies and airways and in the major head and neck reconstruction, that has essentially shut down here in Beaumont because of the requirement to be drilling various bones. That's an aerosolization procedure. And I've mentioned the risks of tracheostomy. At the beginning, in February, there was talk about the risk of laparoscopy, and in fact, our own college has suggested that laparoscopy would not be the preferred option in operating. And this comes down to concerns about the virus being present within the peritoneal fluid in certain cases. I must say the data on this area is very vague. And I think it's a reasonable thing to consider, but it's very uncertain data is all I can say. We have certainly challenged ourselves here in non-cancer work, in laparoscopic appendectomy and working, is this the safe thing or not to do? And I can say to you, we don't have any certain advice or guidelines, and we have tried it, sucking out the air and ensuring it's safely disposed of, but it's a very uncertain area. And the whole approach, I know one of my colorectal colleagues was looking at doing a laparoscopic colectomy for a severe colitis patient, and was more or less told, do it open. And that wouldn't be standard care for patients at the moment. So one of the major issues in the early part of the COVID crisis was that the NCCP, we negotiated with the Department of Health to reverse our protocol for 10 years of trying to centralize cancer surgery, because the cancer centers were effectively unable to provide any elective surgery.
Why don't I have my peanuts?
So let's hope that child gets peanuts.
I just want to wait till I have my peanuts.
Somebody want to mute their Thanks.
Arnie, I'm going to mute everybody, and then you come back in yourself in a second, okay?
Okay, no problem.
Yeah. I'm going to mute everyone now. And
Okay, am I back in now, Kieran?
yes, we have you now, Arnie. Carry on, thanks.
I hope that child gets the peanuts. The issue was we negotiated with the Department of Health to allow us to reverse 10 years of centralization of cancer services. And Michael Conroy in the Department of Health approved this. And the principle was that because the cancer centres would not be able to provide elective cancer care, that we would move out into the private hospitals, given that they were paying 110 million per month to have these hospitals. I have to say, it has not been very successful throughout. It has been successful in some parts because esophagectomies did get moved to the Beacon and to the Blackrock Clinic. But the move of cancer surgery from my own hospital to the Bon Secours Hospital in Glasnevin has not happened. There's zero work going on there. And there's very minimal work that has moved out to the Hermitage. So there's a lot of vacant, empty private hospitals. So it has not been a tremendous success. And essentially, there's very little cancer surgery going on compared to the volume being done in January. And I think when you look at the referral process in my own specialty of breast surgery, mammogram machines have essentially shut down only in absolutely urgent cases. And therefore, that reduces the diagnosis of breast cancer. So we're certainly challenged with significantly reduced numbers coming through. And my colorectal colleagues will have the same challenge because the number of colonoscopies being done are massively reduced. So there will be less surgery because there's less diagnosis of cancers. Other issues in relation to, sorry, I'm just trying to get my screen back. Can the slides be, yeah, thank you. The issue is about outpatient clinics for cancer surgery. There's been a major transition. There's been a lot of phone consultations. Video consultation has been explored. I've done about 8 or 10 of them myself. I actually like them. I think they're quite good. But in an outpatient setting, social distancing is required. So the volume of patients coming to your clinics is dramatically reduced, if not completely. So major changes there. And then the other, those of us who have operated, the protocols are soul destroying. They change every day. There's a lot of confusion about PPE. So I would have breast cancer patients who are asymptomatic, COVID swab negative, and yet everyone's wearing face masks and every form of PPE that you possibly could. There's an hour after theatre where nothing's allowed to happen in the room. There's an hour beforehand. I spoke to a colleague today who did a hip and it took 5 hours of theatre time. So effectively, certainly in Beaumont and in many other centres, to get 2 cases done in an operating theatre in a day would be a major achievement. So there's extraordinary protocols adopted where less work seems to be more successful. It's very frustrating. It's actually soul destroying, and I don't think we could continue to work this way unless we really change the way things are. So I wanted to go through the specialties and say just briefly what's happened in our symptomatic breast clinics. We're just seeing referrals that are deemed highly suspicious, a different triage system. We're not giving neoadjuvant chemotherapy. We're not giving immediate reconstruction, and we're prioritizing the triple negatives to get to their surgery first rather than the ER positive. So significant changes, all guidelines from the Association of Breast Surgeons. In colorectal, most surgeons at the moment, from talking to my colleagues in that, are doing their rectal cancers of those who are already on coming off neoadjuvant. And they have less new cases coming because there's less colonoscopies happening. In neurosurgery, there are no major resections happening here. Diagnostic biopsies are continuing. In head and neck, maybe my colleague Rory will address that, but there has been a substantial shutdown in head and neck cancer surgery. I know Eamon is going to talk later on about urology services. In plastic surgery services, essentially, it's down to excising melanomas under local anesthetic where possible, and there's definitely no major reconstructions ongoing. In gynecology, the workload is significantly reduced. In upper GI, the resections are happening, as I mentioned, in Dublin. John Reynolds and Will Robb have moved their practices to the Beacon and to the Black Rock. And certainly Mylon Arum Gassami has been did a case today in esophagectomy in Beaumont. So moving through the specialties, thoracic, they are continuing. Vincent Young is doing most of his practice in Black Rock for the early lung cancers. In pancreatic, Justin Gagan has informed me they're keeping the pancreatic surgery on the campus of St. Vincent's, mainly in the private hospital, but I understand there are frustrations in access there. Some liver resections have been done in Black Rock in the recent past. So that's a brief summary of where we're at. I only have 9 minutes. I'm happy to take questions at the end. Thank you very much for the opportunity to share some thoughts on cancer surgery. I think the major message is it's been a major change, a massive slowdown, mainly based on the fact that we're uncertain as to what's safe, and we're taking the safe option. And I think as the discussion next week will go on about is what would be reasonable to try and reinstitute some more cancer surgery. I'll leave it at that, Kieran. Happy to take questions now or later.
Okay, Arnie, that's great. We'll take the questions and comments at the end. And again, I remind everybody to use the chat function, type in your question, and then I can put that to the panel later on. An enormous amount of information there, and clearly a great summary of actually where things are at right now. And you know, it's really worrying. I guess the whole point about the diagnostics. You know, cancer is not being diagnosed, and you see it a lot on the social media where the GPs are saying, where are the patients? Where are all the illnesses that we need to look at? And I guess we're only storing up a tsunami potentially of things that we're going to have to try and deal with. So the sooner we start figuring out how we get some services back in action, the better. And that's going to lead us on then to maybe digging in a little bit deeper into some of the specialty areas and what's going on there, and what solutions people are coming up with, or what problems they're trying to deal with at the moment. And that brings us on to Mr. John Kinsella, who is a head and neck surgeon in St. James's Hospital. And John, if you're there, Erica will look after your slides, and as you say, next slide, she'll move that along for you, and then we can listen to what you have to say. So John, I'll hand over to you now.
Okay. Can you put up my first slide, please?
So just bear with us a second, John. Sometimes it's a bit of a delay and just switching over from one thing to the other. So.
Okay. I'm going to talk briefly about the impact of COVID-19 on our management of head and neck cancer. First slide, please. Can I move the slide? Thank you. So the issues are basically who to treat, when to treat, where to treat, what treatment, reconstructive options, as well as patient and staff safety. Next slide, please. We don't have any level 1 and 2 evidence here. We're using guidelines and common sense. Paul O'Neill and Neville were involved in this recent set of guidelines, which was published in JAMA, which I recommend for perusal of any head and neck surgeons who haven't seen them. Next slide, please. So who to treat? Basically, all routine outpatients and all routine ENT and head and neck surgery was cancelled in this country in the middle of March. We're all over the country. All we're doing is, like other specialties, we're doing phone clinics and then calling people for live examinations if we feel after the phone call that they need a thorough examination. Because we're high risk, if we have to look in the mouth at all or in the nose, it's a wet mucosal surface, so we're using full PPE for that. If you look in someone's mouth and they cough, well, then you have an aerosol generating procedure. We're using our usual radiological workup at the moment. There isn't a problem there. We're avoiding panendoscopy if possible. Absolute integral part of a head and neck examination is to do a flexible scope. Beaumont have got in negative pressure rooms, I believe, in outpatients with distal chip cameras. We're still working on that in James's and Tala, and more on that later. Next slide, please. Next slide. Arnie already, back a second, please. Last slide. Sorry, go back again. Back. Yeah, thank you. Arnie already discussed the findings of this study, which put the frighteners on all of us considering any elective surgery. Basically, just to reiterate what Arnie said, these people who were operated on during the prodromal phase of COVID, having various surgeries, ended up with a 1,000% increase in mortality. And the more complex the surgery, the more likely you are to be in that 20% RIP. So this just emphasizes the importance of doing everything you can to try and ensure your patient isn't COVID positive. But as Arnie said, we don't have fantastic methods. Next slide, please. Next slide, thank you. So we, as I pointed out, we cancelled all head and neck cancer surgery around the 14th of March. In James's, we got back into the saddle for non-mucosal cancers last week at Blackrock. Our experience in Blackrock has been diametrically opposite to some of what Arnie has been suggesting. We think it's going to work quite well for us. And And we feel it's probably now time to recommence mucosa surgery, again in Blackrock. Next slide, please. So why Blackrock? Well, for the very reasons that paper that both Arnie and I alluded to, with the catastrophic consequences of a patient either being COVID in the prodromal period, but more so getting COVID in the early post-operative period, as happened to one of our laryngectomy patients in James's who RIP'd. Blackrock offers us a cleaner environment, certainly, than St. James's from a COVID point of view. We feel it's safe out there. We've got it's got a good ICU. We have our senior reg full-time out there. Our pathology specimens go directly to our head and neck pathologist in St. James's. Of course, there are issues. We've no current access in in Blackrock to free flaps. We're hoping that will change. And again, what happens in 2 months' time when the current when the current rental agreement runs out? Can we set up clean, safe zones, including clean ICU in St. James's, or do we need to consider making Tala our COVID hospital, or somewhere else our COVID hospital? Or perhaps, do we need to think again about a dedicated Dublin Cancer Hospital, which has always been my favourite solution even before COVID? I think there'd have to be an awful lot of reorganisational work in St. James's to make it safe for doing complex head and neck cancer mucosa work. We've all read these papers from Singapore, etc., about how they've reorganized their hospitals into separate non-COVID entrances, exits, cafeterias, even COVID teams, etc., and separate COVID ICUs. I mean, we don't have that. We don't have the luxury of 3 or 4 ICUs in St. James's. Next slide, please. Next slide, thank you. So what treatment? Well, obviously, ideally, the same treatment as in the pre-COVID area, but clearly this is not always going to be possible. I think those hoping that we could use chemorads for oral cavity cancers are deluding themselves, really. For oral cavity tumors, such as anterior tongue, if you give chemorads instead of what we've always done surgery, you're going to end up with a poor functional outcome, very likely to have interrupted treatment and a much worse oncological outcome. So I think we have to operate on these. I think there are certain cancers that we have alternatives. For instance, T1 and T2 larynx. I would have thought lasering those at the moment is relatively contraindicated, but luckily we have a good oncological alternative to send them for perhaps 5 weeks of radiotherapy. We've been railing as a group against the use of chemoradiotherapy for T4 larynx, but I think perhaps for certain T4 larynxes, small volume T4 larynx, we've got to consider, do we give chemorads in these patients to avoid the COVID volcano of a patient who turns COVID positive postoperatively with a laryngeal stoma. Obviously, we should use local regional flaps where possible to decrease the number of free flaps, to shorten the surgery, which is positive for the patient and for the staff. Avoid trach where possible, and get the patients out of hospital as soon as possible. Next slide, please. Next slide, thank you. The Irish Microsurgery Special Interest Group have issued this position paper. Next slide, please. Next slide, thank you. Try the next, back one, please. Back one slide, thank you. Back another slide. Yeah. Well, we're missing one slide, and it doesn't matter. Basically, no, go forward a slide, please. Yeah, just say there, Luke. There were in these guidelines, they make several points that you really, if you have a reasonable alternative to a free flap during the height of the COVID epidemic, you should seriously consider that alternative. The authors point out the obvious difficulty of using PPE, doing very complex microvascular surgery down a microscope. How do you keep your cornea free from aerosolized COVID during a free flap, and they recommend against doing bony free flaps during the COVID epidemic. Now, this latter recommendation presents a particular issue, I think, for head and neck surgeons. For almost all other situations, there are alternative, although not so good, options to a free flap. But for anterior mandibular arch, if you resect that and you can't replace bone in there with a free flap, you have a pitiful Andy Gump deformity with terrible functional and cosmetic outcome. A group of plastic surgeons and head and neck surgeons are going into College of Surgeons lab on the 5th floor tomorrow afternoon to try and trial using PAPR and other equipment and a microscope or perhaps loops to see if we can get around this some way. So hopefully there's some kind of solution coming down the track. Next slide, please. Next slide, thank you. Next slide. Yeah, so what about patient safety? Well, we think going on that Wuhan paper, the people before any major surgery, actually before any surgery, should cocoon for 2 weeks and should ideally have 2 COVID negative swabs 48 hours apart, as well as a CT scan of chest in the 24 hours prior to surgery. That's the protocol we're using in Blackrock now. I'm personally in favour of PAPR for all mucosal cases, but there is some debate around that. I think that we've got to consider COVID swabs for surgeons and for anaesthetic staff when we get the testing capacity, perhaps as often as once a week for all of us. Next slide, please. Next slide, thank you. The FFP3 versus PAPR debate, basically, I think there's no doubt that PAPR has filtration advantage over FFP3, which is the same as N95. The argument against PAPR is that you may contaminate yourself on doffing it, and also, you know, how do you? That is a little bit complex to set up. You have to change the filters, etc., and how do you decontaminate it? But certainly in the Far East, where they had extensive experience with SARS and with MERS, the recommendation universally seems to be that for all aerosol generating surgeries, in mucosal surgeries, that PAPR is the standard of care. Next slide, please. Next slide, thank you. That's just another paper pointing out the same thing. The PAPR has better viral filtration than others. Radiation oncology is obviously a very important part of our treatment of head and neck cancers. ASTRO issued this consensus document recently, and the kind of take-home messages there were just a couple of things really. If someone is diagnosed COVID positive before the onset of the radiotherapy, you should delay the starting the radiotherapy. However, if someone is 2 weeks or more into the radiotherapy and they're swabbed COVID positive, but if they have only mild symptoms, well, you should bang on and continue with your radiotherapy. What they're doing over in St. Luke's at the moment is any of their 9 current St. James's COVID positive patients, they're doing them last in the day, but they're still doing them so long as their symptoms are mild. If the symptoms become more severe or they get any hypoxia, they're transferring them across infectious diseases in St. James's. Stuff like hypofractionation to try and shorten your period of radiation and avoiding cisplatin really are only modelled for if your radiotherapy and services are getting overrun, if you have a shortage of staff in Luke's, for example. But at the moment, we probably don't need to go down these routes. Next slide, please. Next slide, thank you. This very quickly here, this is just a paper pointing out the very obvious that basically if you have prolonged or delayed radiotherapy, your oncological outcome is obviously going to be fairly adversely affected. That's why after 2 weeks, if you're in 2 weeks into radiotherapy and you're well, even though you have COVID, you should bang on with treatment. Next slide, please. Next slide, thank you. So what are we doing in St. James's at the moment? Well, as pointed out previously, we're doing no routine work. We've done no cancer work at all at St. James's since the 14th of March. We're, like elsewhere, we're doing phone clinics and only calling patients in for live examination if it's felt appropriate. We're still avoiding the flexi-scope. Now, this is a huge issue for ENT surgeons. It's really a routine part for examination. And normally we just look directly down the head of the scope ourselves, where our face was very close to the patient's face. The patient coughs, and then we get a huge aerosol dose of COVID. So internationally, the recommendations seem to be that we need to get much more expensive distal chip cameras and work off a TV screen rather than just looking directly down a microscope. This is going to involve a big capital input. We also ideally need some kind of extraction system, some air exchange system in the room. And we're working on this in James and Tala, although we're getting somewhat contradictory advice from our engineers and virologists than what people in Beaumont seem to have got. But this needs to be sorted out literally yesterday, but we are working day and night on it. We're using the same, we have no radiology issues as of yet. We still have full access to CAT scan, MRI and PET scan. We've already done some urgent non-mucosal work at Blackrock Clinic. In spite of reservations about what happened in Wuhan with the elective cases, we feel at this stage, 6 weeks out, we need to get back in the saddle and start doing mucosal work and see what happens. I plan actually to do a laryngectomy myself in Blackrock on Monday. Colin Fitzgerald, our senior reg, is full-time out there. We feel the nursing staff can cope with this. But there's huge uncertainty about what's going to happen in Blackrock, with microvascular reconstruction, and much more so what's going to happen in 2 months' time when the current deal with the government runs out. I just don't know. Thank you very much.
John, thank you very much for that. And yeah, lots of questions there. I think that everybody wouldn't mind getting some discussion on. So again, really appreciate you giving up your time tonight and participating in the talk. Our next speaker then is Mr. Eamon Rogers, and Eamon is the National Clinical Advisor for Urology and is probably quite well known to a lot of people, and is broadcasting tonight from all the way from Galway. So hope everything is going well in the West. And Eamon's going to have talk to us about the management of urological cancers during the pandemic. So Eamon, over to you.
Thanks, Kieran, and yeah, we're all well in the West. Thank you. I want to thank you and to thank our President, Ken, just for the opportunity to speak tonight. It's a particular pleasure to be here with my great colleague, Paddy O'Malley, who has pioneered robotic surgery in this country. And the issue of aerosolization and minimally invasive surgery is going to be very important going forward in planning for surgery. So I'm delighted Paddy's views on that. So can I have these slides, please? Eric.
Yes, so Eric is just calling up those slides now, Eamon, so it'll just take seconds. That's great. And again, to remind everybody to use the chat function. I see it's been well used already. And if of course any of the panel who wants to get onto the chat, as Arnie has done already, and answer any questions coming in directly, please feel free to do so. Okay. So I think Eric is just getting those slides ready for you now.
Sure. I can keep talking anyway.
Yeah.
Basically, obviously, Paddy and I are urologists, but we share a lot of common issues with regarding the management of cancer. We're both uro-oncologists by training, and I'm going to share what we think are, and my colleagues nationally, and I've spoken to a number of them, what are the issues generic to surgery, but also some specific to urology going forward. And, as we know, in the last few weeks, we've been basically involved in planning for the surge, where there was an anticipated wipeout of all theatre, ICU, beds, facilities. And thankfully, that hasn't happened. And obviously, thanks, the public response has probably mitigated that risk substantially. So, can we go to the second slide, please, Erica? Number 2. So now we're in the situation where we're talking about a cautious reopening of elective healthcare, mainly time-sensitive cancer in particular. But I think we're now entering a particularly difficult and dangerous era because, first of all, to use a very bad term, the virus hasn't gone away. And yet there is now opportunities and indeed capacity to tackle urgent surgical disease. And of course, cancer is front and center in that. And I strongly feel the bulk of my talk tonight is going to be around, we really do need to plan and prepare for this. I think otherwise it could be chaotic. The Americans are describing this as preparing for ramping up. And I think it's very important that we do plan. Obviously, and that's the purpose of my talk tonight. Obviously, I'll go to the third slide. Next slide, please. Some of those slides are, sorry, they're not, one of the bottom lines is not showing, but anyway, I can talk around it. So there's a few general concerns now for surgeons that need to be aware of if we're going to manage a cancer patient electively, scheduled care. We must be aware, you must communicate the risk of COVID-19 to the patient. It's been shown patients can come in with COVID, or they can get it in hospitals. So it's important that surgeons have that front and central in their thinking, particularly when preparing a patient for this type of surgery, and particularly when they're consenting. The advanced paper makes this particularly important. We know that that asymptomatic patients who undergo surgery, 20% of them died. And it's important to note that this was a range of surgery across a lot of disciplines. It wasn't any particular one type. 44% needed ICU admission. And surgical complexity, which of course is often involved in cancer, was one of the risk factors for a bad outcome if the patient came in incubating COVID but had no symptoms. So we need to be aware of that. And of course, at the same time now, we must be aware that if a patient has cancer, then it will progress. You can't, both are equally important in consideration. And we do have a duty. It's important to remember that in a pandemic, we should definitely have a duty of care to the patient to prevent COVID, to mitigate against COVID, and to stop the cancer progressing. We also have a duty of care to our community. And so the legal term is we must act in the best interests of the patients and the providers. So two other principles are, I'm not going to get into them, is outpatients. The days of sitting in a crowded waiting room are over at the moment. We need telemedicine. And inpatient care, we should limit the length of stay in the hospital. And that's where Paddy, will talk about minimally invasive surgery and robotics, which is particularly adept at that. Next slide, please. So it's important to be aware of a number of factors that surgeons have to consider and the surgical community have to consider during this pandemic. It's important to be aware, if you're bringing a patient into your local hospital, that you speak or find out what is the situation regarding the COVID status in the area or in the hospital. That's why the private hospitals have been useful for many more COVID negative. So it's important to consult with the patient and other public health professionals regarding the prevalence of COVID or the incident in the institution you're bringing in. We're aware that we need to be aware about the supply of PPE. You need to be aware of the availability of staff. 25% of staff in one institution were out because they had either suspected or had contact with COVID. So you need to be sure you have staff to assist you. The bed availability, particularly ICU beds, are important. Ventilation availability. The comorbidity, which was shown in the Chinese study, you need to factor that in. And of course, the urgency of the procedure goes without saying. Blood donation at the moment is low because blood donors are not going into centres to get tested. So you need to be aware of that. The length of the hospitalisation can be mitigated by minimally invasive surgery. And for the last, again, I'm sorry that the last line seems to have not come up on the slide, and it was actually the most important one, but you must be aware of the risk that the patient can get COVID, the risk that staff can get COVID, and that is a classic health and safety issue that you must take into account. But it's not just the individual surgeon. That's why I feel this is a lot of responsibility on an individual surgeon. And I think there needs to be, these issues should be available to a surgeon in whatever local institution or region he's operating in. And there should be some sort of committee that can deliver these stats. My last line there was the most important. We need to know the capacity of COVID-19 testing, as Professor Hill and Mr. Kensler have said. And I strongly believe if we're going to plan, this has to be absolutely standardized in as much as possible. And perhaps I can dwell on that verbally. What do I mean by a national standard? But if we're planning, we are actually planning for a lot of unknown unknowns. So we have to minimize, we should plan as a group, as a surgical community. If we have divergence on different planning, that's going to expose medical legal risk and inappropriate PPE. Just giving two examples. So we know that symptomatically a patient who has COVID shouldn't have a scheduled operation. And it is the asymptomatic patient incubating COVID are the dangerous ones. So what does that mean? On one level, the bird's eye view should be, should a patient come into a hospital in the first place unless they've been tested or checked for COVID? Because a hospital has sick patients and it has frontline staff, which are a valuable resource. So I think that question needs to be asked. Should patients come into a hospital without being tested? I don't know the answer to that, but I feel the question has to be asked. And again, if there is a feeling that they should be tested, well, then that has to be a national standard, not a local standard. You cannot have one rule for Ceuta or one process in Ceuta and another in the Dublin region, because that would expose medical legal risk. The second thing that we share commonly is that most of our patients will require intubation. And as the Chinese study showed, that's a big risk in terms of asymptomatic COVID. And our international guidelines are saying that if you're intubating a patient, you really should test for COVID. Now it comes to the pros and cons of the test. And again, we need to have a national policy on that. That's what's going on in England. They will not do a time-sensitive cancer unless it's COVID testing. But again, we must have a uniform national policy on that, because if we don't, if one group are testing and one isn't, and there's an adverse outcome in the area in the hospital that's not testing, it doesn't take too much imagination to know that could entice medical legal jeopardy. And then, yes, there will be specialty differences in terms of testing for COVID. Aerosolization, I will talk about. I mean, there's issues around gastrointestinal endoscopy because of I understand viral loads of the PSAs, and the Society of American Gastroenterological Surgery advised testing in that scenario for doing GI endoscopy. You could argue, though, is necessary in flexible cystoscopy, where the urine doesn't seem to be as prostate biopsies to me are a particular risk, hugely prevalent cancer. It's the bedrock of diagnosing it. But I mean, there's a 5% risk that a prostate biopsy could have urosepsis and go to a HGU. Now, if he comes in, has urosepsis from the biopsy, and is incubating COVID, that could be a public health fiasco. And again, these questions have to be asked on a sectoral basis as well as the generic ones. But there should be a national policy for each specialty. And then finally, John mentioned this. I mean, what about if we, in reality, I don't know the answers to these, we may not have COVID testing. Cocooning does seem to be a very useful way of mitigating risk of COVID. 75% of patients who are incubating COVID will display symptoms after 7 days. 100% will display symptoms after 14 days. So cocooning for 14 days is very much a fail-safe process. The problem there, though, is how do we police that? Are we sure the patient would have done it? Should we get them to sign a disclaimer? I don't know. But again, these are fundamental questions. Then the use of CT thorax, variable, I think it's a toss of a coin, whether it's valuable or not. The American radiologists don't seem to regard it as that useful. And there's other things like D-dimers, lymphocytes, etc. So, and finally, if we do get COVID testing, there's issues about how we use it. Is it available? What's the turnaround time? What's the false negative rate? And more importantly, many of our patients who undergo surgery will have respiratory issues afterwards, as per GA. Do they get tested? Should they get tested? So these are all the issues we need to consider, and that's why I feel before we need to plan carefully. Next slide, please. So I'll move on now, just due to the time. But basically, the European Association of Urology has issued guidelines, and just quickly, they advise asymptomatic patients undergoing time-sensitive cancer surgery in urology must be tested for COVID-19, along with CT scan and cocooning. An important issue is, I mentioned this about the false negative rate, which there is, as Professor Hill said, with COVID testing. There's no panacea, there's no 100% here as to how we can determine the COVID status of the patient coming in. But I think it's important to communicate that risk during the process of informed consent. In other words, communicate the warts and all issues before we put someone through elective surgery at this time. Now, finally, I move on to Paddy, but just quickly, the European Association of Urology Guidelines have, I've dwelt a lot on COVID, but I think this is a very important issue to protect ourselves as surgeons. But we also must be fairly expedient in getting the cancers done. The European Association of Urology have adopted a traffic light system, which we have found, I think, has been tremendously useful. It's only come out in the last week, and I can thank Mr. Amadi for adopting it to this. And basically, they advocate at this time of operating only on patients who are high priority or emergency. Emergency is life-threatening, and high priority is that clinical harm will happen to the patient if the surgery is postponed for more than 6 weeks. And by harm, they mean cancer progression, secondaries, and death. And as I say, they're now advising time-sensitive treatments for these patients. Next slide, please. And finally, these are our own guidelines that we put out originally about 3 or 4 weeks ago. I want to really thank my colleagues, and especially the specialty leads in cancer. And actually, this outlines the time-sensitive cancers that need to be done, and they're absolutely bang on with the AAU guidelines, coincidentally. So I want to compliment them on that. So that's what we're doing, and that's what we're doing. The question is, what we're doing in urology, that's literally what we're trying to do at the moment. And I'll hand over to Paddy and the
Thanks, David. Thanks for the opportunity to speak. It's a very challenging time for everybody, and we are looking for guidance from varying bodies in relation to patient safety, patient outcomes, our own safety, and the safety of our staff. So if you go to the next slide, please. So in relation to the topic of robotic surgery and laparoscopic surgery, essentially the establishment of a pneumoperitoneum, there's a number of bodies that have given direct guidelines in relation to the COVID-19 pandemic. I've listed the British Association of Urological Surgeons, specifically dealing with laparoscopic and robotic surgery, the American College recommendations, the SAGES document that Eamon adhered to, the ERIS guidelines, who have been very proactive. That's the subsection of the European Association of Urology that deals specifically with robotics and with robotic training, and our own intercollegiate document that has been recently updated in relation to operating on patients in the coronavirus pandemic. So there's a number of considerations that we need to look at when we're performing a procedure that establishes a pneumoperitoneum, such as robotic surgery. So I go to the next slide, please. All of these cases that we're operating on need to be looked at in a fairly strict MDT setting. We've centralised all our prostate cancer surgery amongst the surgeons involved, or ANP nurses in the RAPAC's clinic, along with our radiation oncologists. So these are patients who have urgent, non-emergency prostate cancer that require intervention. We do know that aerosolization happens with different techniques of surgery, especially with the formation of pneumoperitoneum, and it has been demonstrated that surgical plume or carbon dioxide emitted from the patient will contain low levels of HIV, human papillomavirus, hepatitis B, etc. However, there are certain steps that need to be taken as regards safety and to reduce that risk, and we recommend that the use of these steps, which we will go through, do not carry an excess risk to staff, but will bestow advantages on the patients, such as reduced length of stay, which from an oncological perspective is well described, but I think from an exposure perspective, to get somebody back home to where they can re-cocoon or re-isolate themselves is very important, and that's a balance that has to be drawn. Robotic-assisted surgery must involve a patient-level assessment to the risks of minimally invasive approach, again on a case-by-case basis. I won't get into the preoperative screening, but I will speak about the informed consent with regards to the probable outcome for patients who become COVID positive in the post-operative setting. So essentially we have 4 scenarios. We have COVID positive patients who I would not advise, and there is no recommendation that advises they have a laparoscopic or robotic assisted approach. There are COVID negative patients to the best of our ability, insofar as we can CT their thorax, we can do their swabs with a false negative value, and I think that that has to be explained to the patient. They're asymptomatic prior to their surgery, and they remain asymptomatic with negative preoperative testings, but become positive in the post-operative immediate setting, which is a very high mortality, stroke intervention, ICU intervention level. And with the COVID patients who become positive in the post-operative setting, and we have heard cases of patients who have been discharged from well and have represented with COVID-19 symptoms and have not done well in that setting. We're only operating on high-grade, time-dependent cancers, which are ISUP grade 4 and 5, high-volume disease in ISU group 3. So in old money, these are releasing 8, 9, and 10s, or high-volume 7s, or radiologically or clinically have T3 disease or locally advanced disease. And as with all COVID-19 related discussions, these guidelines and the recommendations are rapidly changing, and I think formats like this are very important to be abreast of what's happening internationally in a time-dependent manner. Next slide, please. So when we decided that we're going to perform robotic-assisted surgery for prostate cancer or for renal cancer, you need to minimize theatre personnel. I think this is very important. There is no role for training in these cases. Our ERIS fellow who works with me has been stepped down as per ERIS guidelines. The fellowships are suspended. It's an experienced surgeon who does the case, and the footfall through the theatre is something that needs to be very limited. Practical things like carbon dioxide, make sure it's in the theatre at the start and that there's a supply that will last throughout the case time. Our bedside assistant and scrub nurse wear a level PPE 2, which is full frontal visor, beaked mask, and standard body covering, along with double gloving. We have a circulating nurse as well as that staff, along with the anaesthetic nurse, are the only staff in the theatre. It's important that the anaesthetist is familiar with laparoscopic surgery to minimise the risk of intraoperative problems. We intubate our patients in the anaesthetic room with the anaesthetic nurse and nobody else. And again, there's a strict protocol as regards extubation. Technically, we advocate the use of the AirSeal system, which is a very intelligent system. It keeps your pneumoperitoneum at a stable level throughout the case. It is a closed system and does not allow leakage through the carbon dioxide delivery port. It's approximately €300 and is readily available, and we find very beneficial. We advise that you reduce your skin incision, which is easily done by marking the dimensions of your ports at the very start. A point that is challenging is that to run your pneumoperitoneum very low, our standard pressure will be 15, but with the use of Trendelenburg, we're able to reduce that to about 8 to 10 millimeters of mercury throughout the case, which again reduces the risk of carbon dioxide escaping throughout the procedure. Next slide, please. So once the procedure is completed, we set our pneumoperitoneum setting to 0 before there is any port removal. The ports are capped to allow any leakage through those. You carefully evacuate the carbon dioxide through a laparoscopic suction device, which is filtered. The difficulty here is that, specific to robotic prostatectomy, you need to insert a surgical drain into the pelvis. And that's usually done through the largest port, which is the 12 millimeter port in the left iliac fossa. What we do then would be to remove that port around the drain, but that would give you a large movement of carbon dioxide from the pneumoperitoneum into the theatre environment. So to reduce that risk, what we can do is we can technically grasp the drain, and you can angle your instrument to tense the abdominal wall. You can then slowly evacuate the pneumoperitoneum whilst leaving the ports intact, and that has worked well in the case that we've done to date. The difficulty here is that your suction can involve small bowel viscera and cause an unrecognised injury at that late stage, but that's something that we've been able to avoid. There is a recommendation that we use the ultra-low particulate air extractions. These are very, very cheap. They can be adapted to any surgical suction, and they can also be adapted to the use of the intraoperative air seal. So there's a very small filter in these for particles. There's an air and fluid trap, and they're removed from the system and disposed of. They're not expensive. Another good technique that we are using is, people may or may not be used to using this Megadyne diathermy pencil, which has normal cut and coagulation functions, but it also has built-in hooded suction where the surgical fluid is immediately evacuated again through a filter, and that's a closed system, and we're using that. The added function to this is that if you use diathermy and cut together, that is just starts the suction flow by itself without any diathermy injury. They're both made by a company called Megadyne. They're inexpensive, and they're again readily available. We use the XI system, which has very small port sites, but the use of the 12 millimeter suction port and the administration of sutures, etc. Through that, it is important that you put the space around that. So the instrumentation goes through the 8 millimeter port with a seal around the other 4 millimeters dimension of the port, which is important to prevent escape. We use between a 15 to 20 degree Trendelenburg position, and we obviously try and have that as low as possible, as it reduces any pulmonary compromise. And the other part of the guidance is that in the use of ultrasonic cautery, that can generate a very thick smoke plume, and it's advised that you don't use that. We use simple Merlin bipolar and monopolar scissors as regards our energy. Next slide, please. So that's essentially the techniques that we're using to reduce the aerosolization from pneumoperitoneum. They've worked quite well. We interrupted our robotics program for a week until we looked at this and took the advice on board that was available. Essentially, we've been operating on approximately 5 men per week since the recommendations were put in place, which has delayed slightly but has not really impeded our access for high-grade cancers. We currently have approximately 80 men on our waiting list. The vast majority of those have intermediate risk prostate cancer and are not of a concern for the next 3 to 6 months. But I think by doing this now and safely, we're going to avoid the backlog of patients that we will inevitably have once our diagnostic program starts up again. So I'd like to thank our nursing and anaesthetic colleagues who have been very helpful in setting up this program. during the COVID crisis, and hopefully we won't have any adverse outcomes. So thank you.
Great. Paddy and Eamon, thank you very much for that very interesting understanding of what's going on in urology, and lots of questions. So I'm going to put some questions to the panel. So guys, if you're kind of have your fingers at the ready to unmute if you want to come in, and what I might do is that we've had a number of good comments coming in the chat line, and remind everybody to use the chat function to put our questions to it. But I'm going to start off and maybe ask Arnie. Arnie, the 4 colleges and the ASGBI and so on in the UK and our own college has put up a kind of a guidance on the priority of surgeries that are we can't really wait any longer, that maybe can be pushed out for a number of weeks but will become very urgent. So the whole time dependency thing. And what's going on at the NCCP in that regard, and are they using a similar framework?
Yeah, as you say, most of them have the various societies that have given their recommendations. So in breast, the Association of Breast Surgeons have made a pretty sensible recommendation of what you can and can't do and what you can put off. So elderly with hormonal positive, ER positive breast cancer can go on hormones. Young triple negatives, you want to get operating. And I was saying, avoiding neoadjuvant and avoiding reconstruction. That's the current plan. And NCCP have put out a guidance document based on, so Eamon has fed in the urology one, and as John has suggested, the ENT have reduced their volume significantly in terms of the work that they're doing. So we have a document that outlines what each specialty are doing, but they're based on national recommendations elsewhere.
Great, thanks. And I suppose, that's a reasonable framework for everybody to sort of, I guess, understand that framework, get to understand what's being recommended by their own societies and so on, and that may help them start prioritizing the work in their own hospital. Is that fair to say?
Yeah, I think it's fair to say, but I think people are trying to think about how they can get back and do more work and what's reasonable. I think we're at that phase of people accepted the initial shutdown, but I think we're trying to work out what's safe. And you know, you heard from Paddy there, very reasonable things to do in laparoscopic and robotic surgery. I think we're just on a journey of trying to work out what's safe. And, you know, a lot of it is that the difficulty we have with knowing who is truly negative is challenging.
So that leads on nicely, because one of the themes I think across everybody's talk tonight was the absolute need for testing, and the need for the testing to be as accurate and as reliable as possible. And at the moment, it's not quite there yet. And we had a very good comment here from a colleague on the chat line asking about the issue really is around what is the community transmission rates. It would seem that the surge that we were expecting probably hasn't quite emerged, and that's a great testament to the early action taken by everybody and the compliance of the community on this area. But it certainly means that we have to have an approach to testing that will work. Does anybody want to kind of comment on, because it was mentioned, do you test before they come into hospital, do you test in hospital? What would you think is the best way to deal with that? And I'm happy to, maybe John, maybe you'd like to comment on that.
Yeah, I think cocooning is probably more important than testing. And I think that needs to be stressed to the patients. You've really got to get that message across. There are a bunch of different recommendations from our point of view, from like ENT UK, etc. We're suggesting a 48 hours apart COVID swab. To be honest, the COVID testing is more to protect the patient and the staff. We've got to work on the assumption that everyone you're operating on is COVID positive, just like we did in the past with other infectious diseases. So we've got to, work on the safety principle that everyone you're operating on for next year is COVID positive. So really, and that needs to be emphasized to the patients as they cocoon. The cocooning and the COVID testing is not to protect the surgeon; it's to protect the patient.
But John, you mentioned that if we presume everybody's COVID positive, and then the current literature is there, and that was quoted by many of you, was that these patients then are at a much higher risk of complications leading to death following surgery, essentially, that you wouldn't necessarily normally accept or be part of our kind of surgical regular mortality rates at the moment. So does that?
No, I'm not that clear. I mean, from a staff precaution point of view, we've got to, anytime, as a head and neck surgeon, if I'm doing a mucosa surgery, irregardless of whether the guy's cocooned for 2 weeks, irregardless of whether his CT chest is clear, his 2 swabs are clear, I'm still going to recommend to my registrar, myself, the nurses, that they take full anti-COVID precautions. The COVID testing is, if it's positive, is to protect the patients, because then you don't operate for surgery. That's the point I'm making.
Okay. Does anybody else want to come in and talk more on the testing issues, the approaches that we're taking at the moment on that?
Kieran, yeah, just we don't know what is the appropriate level of testing. So I agree with John. I think cocooning is probably the safest method. And again, but it's policing it. I just think it's difficult, but it is. And then you're trying to schedule an operation to meet the cocooning requirements. So I think scheduling is going to be an issue with that, but I think it is very important. And I suspect, and this is why I think we have to ask the questions, I think the availability of COVID testing is going to be limited. And then there's the false negative rate. And I think you have to consent the patient explaining that you have exercised whatever is available to mitigate against COVID. But there's still a chance that you won't detect it. And that has to be brought into the consenting process. I think that's really important.
Can I say one more thing? There was an interesting article by an economist in one of the weekend newspapers, an American economist, saying that the only way economically we're going to get ahead of this mess is to test the entire population every 2 weeks. So, he was saying that it'll be cheaper to make that availability to the entire population than what this virus is doing to us economically, apart from medically. Thank you.
Yeah, I think it's a fair point. And just moving on from the testing, and I guess that's going to be a very ever-present issue for us all to kind of get the testing, and clearly then the whole protection of staff and protecting patients and balancing all those is really important. But John, you mentioned something interesting, that like in Singapore they kind of went with a COVID positive and COVID negative, say ICUs, and we couldn't have multiple ICUs in our hospitals. But actually, the whole reconfiguration of how we've used to do things is going to have to change. COVID is likely going to be with us now for 18 months, 24 months, who knows? And actually, we're just going to have to rethink how we've actually structured our whole hospital system. Any ideas on what sort of plans we should start putting in place now?
We first of all need to know what's going to happen in 2 months' time. I think the safest thing to do is to have a clean, non-COVID hospital, be that Blackrock Clinic, be it Ella, be it the Ioneer in our case. You can do your zoning like they've done in Tala Hospital, for example, like they've done in National Maternity Hospital, but I still think that ain't half as safe as having a clean hospital.
Does anybody else want to talk about the kind of the way we should maybe approach looking at our hospital infrastructure?
I think it's impossible to keep the hospital clean once you allow patients in the door. Someone's going to come out with it.
I agree with that. I think it's a real challenge.
Okay. It was interesting, Paddy, when you were talking about the technological side of things, and there's been lots of debates maybe on the robotic side, in say normal times, but clearly technology is going to play a big part in how we deal with the COVID risk and the aerosolization procedures and so on. So is it time now to start looking at these technologies and building them into our into different areas of surgery and surgical practice?
Yeah, I mean, it's obviously not the right environment to try and develop the application of robotic surgery, but certainly from a safety point of view, it's a very structured approach. It is high end from a technological point of view, but it's a very reproducible operation. And from that perspective, I think that it's something that your staff cohort are very easily trained for modifications in relation to PPE, in relation to reduction of aerosol, etc. I must say personally, my biggest concern is that you have a patient who has no symptoms, who has gone through whatever screening procedure we put in place, but either has asymptomatic COVID or gets COVID in the post-operative setting. I don't think anyone can mitigate against that. And I think regardless of what type of surgery you have, the complexity of the surgery that you have, specifically if you have a cancer diagnosis, you're at a much higher risk of infection perioperatively, regardless of what the infection is. So it's a scary situation to be in, but I think we have to be more so united in the approach, in the information that we can give patients to the risks, on top of the possibility of adding a perioperative COVID infection into the equation. And I think that's going to become the big challenge, irrespective of the work that's piling up, the non-COVID related pathologies. I mean, there's people sitting at home with their PR bleeding, with their abdominal pain, with their chest pains, etc. And that's all going to start to come more apparent once the restrictions are lifted and people see that it's important to attend doctors and get back to hospital again. But yeah, I think robotic surgery has a role in that regard, but not anytime soon, I think, in the current environment.
Makes sense. Any other comments on that, or will I just maybe the last question I suppose I have, and as maybe it's kind of almost like a something that the college is trying to get our head around, is the massive impact that the cancellation surgery, not only on patients, but on training, and the impact on our trainees, and trying to figure out the pathway by which we can build back in the experience and the training for our surgeons. I would like to comment on, you know, what they're seeing as maybe some of the opportunities that emerge.
Well, I think, Kieran, it's really challenging, not only for people in this current job, but those going to jobs in July. So, for example, I have an SPR is due to go to a breast reconstructive fellowship next year in the UK. Well, there will be no breast reconstruction done, so there's really no point in our going. And that's, you know, a really difficult time for them in their training, where the service is just not available. They can't be trained in it. So there are examples of that happening, and currently the volume is dramatically reduced. So it's very challenging.
I just make a comment here. I think it's going to be really difficult because your peers expect you to do the surgery as a consultant and get in and out there as quick as possible. So training, you know, is going to be, you know, they're not going to tolerate that if there's any delay in teaching, and you need to take someone diligently through various steps. So I would be very concerned about surgical training at the moment, certainly at this point in time.
Yeah, it's very challenging, especially for us insofar as our directive. We're lucky to be an ERIS training centre, and our directive from ERIS is that the fellow must step down, that this is a consultant provided service at the moment. I mean, the other aspect of it is we were lucky insofar as we could remove robotics from the University Hospital to Galway Clinic, and it allowed us to do open time-dependent cancer surgeries. But we again did those, we buddied up consultant-wise and did them with two consultants operating together. So again, you're squeezing out junior staff and training in that scenario. But I think it's an impasse. I think it will eventually get back to some form of normality in relation to volume. I think it's a period whereby it's very fluid, but I do think that the country as a whole needs to be commended on how we've dealt with this. You know, there's been huge sacrifice in society, not alone in just medicine, but I think we're getting to a stage where hopefully some form of restrictions can be lifted. Yeah.
Okay, well, guys, look, it's heading towards 7:30 now, and that's been a fabulous discussion, I think, on where things are at right now with the cancer surgeries and so on. I appreciate all the speakers for, again, giving up their time and sharing all their information with everybody tonight. We had a great turnout, as always, in the webinar. And just to wish everybody a very good evening. And as we've traditionally done with this, I just invite the President just to, if he's any final thoughts or comments to make on tonight's discussions, and then we'll call it a night. So Ken, if you want to come in for a second.
Thanks, Kieran, and thank all the speakers. I think Kieran asked me to come back in at the end just to make sure I don't clear off in the middle of it and have my tea. So although you can see that from the chat function, who stayed here. I really enjoyed that. I thought we had really thoughtful presentations from all of our speakers and many insightful comments on the chat function. I think the topics that came up in terms of zoning of hospitals, keeping clean or dirty hospitals, public versus private, these are really very important issues that really we want to be part of that conversation in the coming months. I think it doesn't take away from the fact, however, that the testing is a problem, because even if you have a clean hospital or a clean zone in a hospital, there is always an issue that patients or staff members, for that matter, may become positive, unbeknownst to all of us, despite the testing. Now, it is possible with repeated testings, with different primers, with the PCR, it may increase sensitivity. And with the gene expert point of care testing, which is becoming available probably in all the hospitals in the next week or two, that may help. But these are the issues and the topics that we will try and address maybe in a bit more detail. I would encourage all of you to perhaps use surgical affairs in RCSI as a central repository. Send in all your the guidelines that you're using, the guidelines discussed for head and neck surgery tonight and for urological cancers, I think are very helpful. And I think by putting all of these together, we may be able to advise surgeons how best to go forward in the future. The training issue that came up tonight, I think, is something that is a current concern for all the colleges. It came up at our intercollegiate meeting that we had yesterday. And I suppose it's also timely because the COVID effect on training has come about as we're going to introduce a new curriculum, which is really competency-based. So this is going to be an issue for the future in any case, in which progression through the curriculum and the training process will be based on competencies. And it may be that some of our trainees will take a bit longer to develop some of the competencies that we're describing here. But all we can say is nobody as such will be disenfranchised. It's the same for everybody. It's the same for all trainees. And we will have to look at ways perhaps to give some trainees that are at critical times in their training additional time, if need be, before they come to CC to completion of their training. I'll end by thanking Kieran and Padraig, but also Erica Sullivan and Paula Mansell, who's there in somebody's back room. I don't think they're in your back room, Kieran, but they're in somebody's back room for supporting the technology. Certainly, I find these webinars informative. The number logging on would suggest that our fellows and members are finding them useful. So I would encourage feedback, as always. Thank you for taking part, and again, thank all the speakers.